We have with us today Dr. Albert Liu, who's the Clinical Research Director of Bridge HIV within the San Francisco Department of Public Health and Clinical Professor of Medicine at UCSF. His research focuses on conducting clinical trials of novel PrEP agents and evaluating implementation strategies to support the equitable scale-up of PrEP in real-world settings. He also serves as co-chair of the PrEP committee of the San Francisco Getting to Zero Consortium. Thank you so much for being with us today. We're very excited to hear from you, Dr. Liu, and I'll hand it over to you.
Great. Thanks so much, Dr. Bloom, for the introduction. And it's really a pleasure to be here and to share some of the findings from the STAY study. I apologize, I'm getting over a cold, so hopefully my voice will not cut out too much. But here, can folks see my slides okay? Great. Okay. So I'm going to talk about the STAY study, which was a PrEP demonstration project. It was a research project for transgender people in the San Francisco Bay Area. This was funded by the California HIV/AIDS Research Program and was a collaboration with folks at the Department of Public Health, Bridge HIV, the Center for Public Health Research, which Erin Wilson was leading, and then several community partners, which I'll tell you about. So just a very quick background. We know that trans and non-binary people are disproportionately impacted by HIV around the world. Compared with the general population, trans feminine individuals are 66 times more likely, and trans masculine individuals 7 times more likely to have HIV. And in the US, while the HIV prevalence among adults is less than 0.5%, the prevalence is almost 19% in trans women and 2% in trans men. And we have seen in recent years that new HIV diagnoses have increased 5% in trans women and concerningly 44% in trans men. And trans people of color bear the greatest burden of the epidemic, with nearly half of 41 to 46% and 26 to 35% of new diagnoses occurring among Black and Latinx transgender people. Here in San Francisco, over 30% of trans women are living with HIV, and new diagnoses are more common among Black, Latinx, and people who inject drugs, as well as youth. Right when the project was starting, we did have some data on the PrEP continuum, and in men who have sex with men, which was from the National HIV Behavioral Surveillance Study, NHBS, as well as in trans women from a study that Erin Wilson was leading called Transnational. And so this kind of set the stage for what we were trying to address in the project. And what you're looking at is the PrEP cascade, or the PrEP continuum, looking at starting with PrEP awareness, talking with a provider about PrEP use, and then on PrEP and reporting that they were adherent to PrEP, taking 4 more doses in the past week. And in the sort of the teal color are trans women, and then the yellow are men who have sex with men. And you can see at each stage of the continuum that there's a drop-off or lower awareness, talking with a provider, as well as PrEP use and adherence in trans women compared with men who have sex with men. Additionally, we saw that there were significant differences in social determinants of health, and specifically compared with MSM, trans women had significantly lower education, lower income, less employment, more likely to report being homeless. However, interestingly, they were more engaged with providers and more likely to actually have health insurance. So with that background, we had proposed the STAY study. We had 3 goals. The first was to develop and implement a comprehensive outreach strategy to maximize PrEP uptake, as well as a support strategy to support PrEP adherence among trans people. And this was predicated on the fact that many of the campaigns and messaging were really focused on MSM around PrEP up to that point. Additionally, we wanted to develop an efficient PrEP delivery system, and we wanted to work within trans-specific primary care clinics in the San Francisco Bay Area. And then finally, our research objectives were to look at the uptake, feasibility, acceptability, and effectiveness of PrEP delivery and implementation among trans women and men in four specific trans-specific clinics in the San Francisco Bay Area. And so we initially came up with a model for the project, which I'll tell you about, and then I'll show you later on how the model adapted and changed as we faced some barriers and things that came up in the project. Several of the key characteristics of the model include having it be peer-led. We felt that that was a really important component, community engaged, driven by data, as well as harnessing technology to help support uptake and adherence. This is focused in the Bay Area, and it was really initially centered in primary care medical homes. And we'll show you those 4 clinics. There were sort of 2 main goals here that you can see. First is to increase PrEP knowledge and linkage. And we had several components of that, including trans community social marketing campaign, which I'll show you, use of peer navigators outreaching through their own networks, having some online PrEP educational tools, and then peer recruitment and referrals. In terms of supporting trans folks who are starting PrEP and continuing on PrEP, we had several components of the model, including delivering PrEP in trans-specific clinics, having training for providers and detailing to support them, peer navigation support, including adherence counseling and panel management, insurance navigation, and then some novel adherence support tools, including a text messaging program called PrEPmate. So this is our campaign that we had developed. It's a social marketing campaign that we involved 12 diverse Bay Area trans and non-binary social influencers. And the sort of idea behind the campaign was trying to harness the power of PrEP to highlight the diversity, beauty, vibrancy, and resilience of trans and non-binary communities, rather than just deploying messaging that focused on HIV risk. So we had our social influencers develop and incorporate their own personal messaging about PrEP and come up with taglines. And so the study is called Stay. So the idea was, adding PrEP to your daily routine won't lead to huge changes in your life, but it could help you stay magical, help you stay aware, stay sexy, stay resilient. And so this campaign was featured on our website, as well as on a print campaign, posters and palm cards, which were distributed throughout the partnering clinics, and then also distributed via social media and at outreach events. So this was a website, staystudy.org, that had information about the study, information about PrEP, and included videos from some of our social influencers talking about PrEP, had a frequently asked questions about PrEP, and then information about the team at the various clinics. This just shows our social influencers, and if you click on these, you can find out more information about them and hear their videos or watch their videos about their experiences, what their thoughts about PrEP. At the same time, the San Francisco Department of Public Health also launched a campaign called PrEP Supports, which featured different communities. And one of our navigators here, Christina, was featured in the program, which also helped us raise awareness more broadly in the community, and it was quite helpful that, it was timed sort of around the time that the project was starting. We did do some assessments with participants who enrolled in the study, asking them if they had seen the campaign and what the impact was. And what we learned was that almost all state participants were aware of PrEP, having seen various campaigns, including the state campaign. About 40% had seen the state campaign. Most found the campaign to be attractive, informative, and appropriate, tailored for trans and non-binary people. And 83% of people surveyed reported that they could see themselves in the campaign. On the right, you can see this was at one of our community forums where folks could take pictures and come up with their own hashtags. So these are our partnering clinics that we worked with as part of the STAY study. There were 4 community clinics. 2 of them were within the Department of Public Health, the Castro Mission Health Center and their Dimensions Clinic, and then the Tom Waddell Urban Health Center and their Trans Tuesdays Clinic. Additionally, we partnered with the San Francisco Community Health Center and the Trans Thrive program, and then the Tri-City Health Center, which is down in Fremont in Alameda County. And then this is our team based at SFTPH, and you can see the co-principal investigators, Erin Wilson, who's done many years of research working with the trans community, our study coordinators, as well as our research associates and navigators as well. And then just our community partners at the San Francisco Community Health Center and Transvision. So a bit about the timeline. The study launched in August 2017. We continued enrollment through June of 2019. And then it was a 12-month follow-up study for folks starting PrEP. So the final follow-ups happened in June of 2020. You'll notice that the last part of follow-up basically landed right at the beginning of COVID. And so it really disrupted our ability to, many of the clinics were closed at the time. And so it disrupted our ability to have in-person follow-up visits, but we tried to, get people in virtually, but you'll see that in some of the final numbers. In terms of recruitment sources, since we were collaborating with the clinics, we were largely trying to do clinic-based recruitment, but we also did community recruitment as well. And so it broke down to about 68, about 2/3 were clinic-based recruited, and then about 1/3 were recruited through the community. And you can see the sort of various sources here. So this shows our study flow. So we assessed about 193 individuals for eligibility for the study, and they were approached and provided information about the study, and about 158 of those enrolled in the study. You can see reasons for exclusion, which included some issues with insurance and cost that prohibited them from accessing PrEP at the site at the time. Having other comorbid medical conditions. One participant was living with HIV already, and then there were a few other reasons. And then there were a number of folks, about 19 folks who were eligible but chose not to enroll. Some of them just didn't come back, about 14. And then there was just one who had concerns about PrEP and hormone interaction, so not a lot. Interesting, one provider felt that the participant didn't need to be on PrEP, which we did not agree with. And then finally, one person transferred to another clinic. So our overall PrEP uptake was actually quite high among those who were eligible, about 87%. And we heard a host of reasons that participants joined the study and were interested in taking PrEP. Probably the most common reason was just to protect themselves from HIV. So I think it reflects that the population was well aware of their risk for HIV and are motivated to prevent acquiring it. You can see some other reasons listed here, including wanting to help their community, and as well as reimbursement for, we did pay folks for being part of the study, or coming in for their study visits. Who did we enroll? So these are some baseline characteristics of the 159 participants who enrolled in the study. The mean age was 37. About a little over 3/4 identified as women or trans women. About 6% were man or trans man. 6% were gender non-binary, non-conforming, or genderqueer, and about 10% reported another gender identity. In terms of race ethnicity breakdown, 3/4 were people of color, so 25%, 24% white, 14% Black, 27% Hispanic, Latinx, and then 27% were other multiple race ethnicities. We did have a range of educational attainment. As you can see, about 16% had less than high school education, about a third had completed high school or GED, about a third had some college, and 16% had a college degree or higher. And then these are some other characteristics. About a little over 1/4 were born outside of the US. And we had a range of housing status, including 23% who reported they were homeless, living in a shelter or couch surfing, about 15% living in a hotel, SRO, or other institution, 54% owned or rented their place. The other thing was food insecurity was quite common. About 74% reported having food insecurity sometimes or often. And then most similar to that survey, the transnational survey, most participants did have a primary care provider, had health insurance. 79% were actually taking gender affirming hormones. And 32% had reported having gender affirming surgery. And then just a final few characteristics just to share. It was actually a quite tested group. About 77% had tested within the last 6 months, and PrEP knowledge was quite high. The majority had never used PrEP before. 11% had used it in the past, but were no longer using it at the time of enrolling in the study. And about 30% were actually on PrEP through the clinics that they were recruited from. The median number of sex partners in the last 3 months was 2. About 40% reported condomless anal sex or vaginal sex in the past year. About 22% had an STI in the past year, and 23% were engaging in sex work currently. Finally, mental health issues were common. 42% reported depressive symptoms, about 30% post-traumatic stress disorder, and then 39% anxiety symptoms. 18% had experienced violence, and that recently, and about 1/4 experienced unfair treatment by doctors, and 15% distrust of doctors. So that gives you a snapshot of who enrolled in this study. So I mentioned that we did encounter some challenges with PrEP implementation in our clinic. So I just wanted to share some of those before we dive into the data, because we did change or expanded our delivery model sort of partway through the project. So these were some of the challenges that were faced in the project. First of all, there was just a lot of turnover of staff within the clinics that we were working with, including both the peers as well as the medical providers. And we actually had turnover of 2 of the 4 site principal investigators, and one of them multiple times during the project. So there's just a ton of turnover happening. Also, we found that the intake process within our own San Francisco Department of Public Health clinics turned out to be a big barrier to starting PrEP and starting primary care. And in fact, for folks who were community recruited, we tried to we've referred them to those clinics, and often they had to have multiple visits scheduled over a 6 to 8 week process with orientation and other multiple visits that they had to attend before they could even see a PrEP provider. We also came into, or we discovered that that often the stay team and the clinic team had differences in who they thought would be a good PrEP candidate. And we purposely had our criteria very broad, and pretty much if someone wanted to be on PrEP, we were supportive of that. Whereas some of the clinic staff felt that, we don't think they really need PrEP, and so that turned out to be a barrier. And finally, just the the quarterly follow-up visits that was part of the PrEP protocol turned out to be a significant burden for providers in clinic and the staff, where they weren't used to having the patients come back so frequently and requiring labs, and so that turned out to be another barrier. And so several partway into the study, we sort of came up with this idea that could we add an additional site that was really just focused on PrEP delivery, trans-specific PrEP delivery. We thought that since our research clinic at Bridge HIV was very centrally located in San Francisco at Van Ness and Market, and that we could offer more flexible hours and reduce some of those barriers that you saw on the last slide. And so we partnered with our peer navigator, Christina, you can see here, to really have a peer-led trans-specific PrEP clinic. We had our nurse practitioners who conducted the clinical parts of the visit, and then the peer really led all other parts of the visit and consulted us as needed throughout the project. And what we found was that, we unfortunately started this late. We started it when there were only 4 months left of our recruitment period. But you can see here that the PrEP-only clinic at Bridge is shown in orange. And for those 4 months, we recruited pretty much the same number as the other clinics did over 15 or 12 to 15 months for the other sites. And so you can see the numbers here. So it was really quite an efficient approach, and people seem to like this model. We also found that the Bridge, the PrEP-only clinic tended to reach a different population than those based in the primary care primary care settings. And so this Bridge, the clinic at Bridge, folks who enrolled here reported higher levels of sexual risk, drug use, and mental health issues and were actually less likely to be on PrEP. So you can see here comparing the primary care sites and Bridge HIV, there was slightly less to have a primary care provider, had reported more total number of sex partners in the last 3 months, were more likely to be engaged in sex work, as well as report non-injection drug use. You can see here higher levels of depression, anxiety, as well as PTSD. And then only 17% were on PrEP at baseline compared to the 32% in the other 4 primary care clinics. Moving to our results from the study, this slide shows you the follow-up. There were visits at 1 month, 3 months, 6, 9, and 12, and we tried to coincide the study, visits with their actual clinic visit at the same time. It didn't always happen that way, but we tried to do it at the same time. And so you can see there were 2 main procedures, study procedures. There was a survey that they completed, the interview, and then a DBS, which is a dry blood spot, which is a way to more objectively measure adherence level or adherence to PrEP, because you can measure tenofovir diphosphate levels. So you can see that we did have some drop off over time, and particularly, at the 12-month, there was a drop off in terms of not only those who completed the visit, but specifically the number who we were able to collect blood, because that was during COVID, the startup of COVID, and we really were unable to bring people in to get their blood drawn. But overall, the retention at 12 months was 60%, which interestingly was very similar to the retention we saw in another PrEP demonstration project we did earlier, which was focused on mostly on gay and bisexual men. So it was good to see. And so this slide shows what we're calling state participant engagement over the 48 weeks. For each of these bars is a different visit at week 4, 12, 24, 36, and 48. And what we're looking at is the purple means that the person did not come in for a visit. The orange means that they came in but were not able to provide a dry blood spot. And then the yellow means that they did have a dry blood spot, and it the tenofovir level corresponded with them taking less than 2 doses a week. Blue was 2 or 3 doses per week, and the greenish color is 4 to 7 doses per week. So you can see that to begin with, at 4 and 12 weeks, there are a substantial number of folks who have high drug levels, as well as intermediate drug levels. It does sort of taper off over time. But again, some of this, especially at week 48, was due to COVID. So the next thing we looked at was we wanted to see what were some correlates or associations of participant characteristics with retention, study retention in the study. And so what you're seeing here are some of the characteristics that stood out. It's showing the percent of visits completed for each of these groups. And so some things I want to highlight are we did see some differences in retention by sites. And I just labeled the primary care clinics 1, 2, 3, and 4 to protect their confidentiality, and then the Bridge HIV clinic. You can see that the retention was actually highest at the Bridge clinic, with an odds ratio of six-fold higher, which was significant. And then also older age was associated with higher levels of retention for those 36 and above. I should say that the green means that it was associated with higher levels of retention, and the yellow was associated with lower retention. So interestingly, folks who reported PTSD or post-traumatic stress disorder are actually more likely to be retained. And I think that requires some more exploration for why that is. And then also interestingly, those who reported condomless anal sex were somewhat less likely to be retained. And then finally, Latino Hispanic individuals were a little bit less likely to be retained overall. And then this next study is looking at predictors or correlates of having protective PrEP drug levels within dry blood spots. And so, again, here are some variables which stood out. You can see that several of the sites had higher levels of, so this is looking at the proportion of the dry blood spots that had 4 or more pills per week, which has been shown to be associated with high levels of protection. And so you can see that Primary Care Clinic 4 had the highest adherence by VBS, and then the Bridge Clinic was second highest. Again, and then also higher education was associated with higher levels of adherence. And then housing compared with those who were homeless in a shelter or couch surfing, we saw higher adherence in those who were in an SRO or hotel or owned or rented their space. Finally, food insecurity was associated with lower adherence and protection, 54% versus 76%. And then interestingly, anxiety, which is similar to the, I think, parallels the PTSD finding and retention, anxiety, those who report anxiety were actually more likely to have protective drug levels. And we also looked at whether gender affirming hormones affected people's drug levels, because there was, some concern in the community on whether PrEP was leading to lower hormone levels. And, obviously it would be concerned about that. So, and there have been a number of small pharmacology studies, which have, some of them have pointed to slightly lower drug levels in people using trans women using gender affirming hormones. But what we found was that there was no association with self-report of use of gender affirming hormones and tenofovir levels. In fact, slightly higher proportion were protective in the group using gender affirming hormones versus those non hormones, 59 versus 55%. So that's reassuring finding. We did ask people what were some barriers to being on PrEP throughout the study. And so this is if they reported any of these barriers at any visit, including at their first visit. And you can see that not very many people reported that many barriers, but the most common ones were concerns about medication side effects, concerns about difficulty with taking a daily medication. 8% reported concerns about interactions with hormone therapy. And then 6% reported fear of being seen with HIV medications. We also asked folks what were some facilitators to being on or staying on PrEP throughout the study. And again, they were included here if they reported any of these facilitators at any visit throughout the study. So the most common facilitator was having support from my provider. The financial incentives, 46%. The reminder text messages through the PrEPmate, which I'll tell you more about, 43%. And then having insurance coverage, as well as the low copays and transportation to the clinics. I did want to share with you, a little bit more about now some of the services that were provided through the study as part of the state model. And I mentioned earlier that peer navigation was a central piece of the state model. And so what did PrEP or what did peer navigation actually entail? So these are different services that the navigator would check off on a form, on a checklist at each visit if they did this activity at that visit. And so this is whether these activities occurred at any visit during the study. So you could see that PrEP education pretty much happened for all participants. Also PrEP adherence counseling, trans health education was quite common, addressing PrEP concerns, HIV prevention education, HIV STI risk reduction counseling was done in about half of participants. And then about a quarter needed PrEP access support. About 22% were referred for other trans-related healthcare issues. And then 17% had benefits counseling insurance. I will say I forgot to mention that in the study, participants did have the option of either receiving free PrEP through the study, or if we could write a prescription and then they would get it at the pharmacy. So those were two options of accessing PrEP through the study. And then we asked people after the study or during and after the study through a computer survey if they could give us feedback on the peer navigation. And you could see the scale at the bottom. The teal color is excellent and very good, good, fair, and poor. And you can see that really the vast majority of folks felt that the peer navigation services were of excellent quality. It connected them to resources, supported them in taking PrEP every day, helped them be in control. They felt that the navigator explained things clearly, showed care and compassion, listened, and also made them feel at ease within the clinic. And then I just wanted to share some thoughts about why the PrEP-only clinic at Bridge HIV was successful for some trans folks who access PrEP through the PrEP-only clinic. So here's some quotes. Even though I get trans-specific care, it is a clinic for cis people. I like this clinic because it's just for me and my needs. Sometimes I have health insurance and sometimes I don't. So my healthcare is always changing, which makes establishing primary care and getting PrEP really difficult. I don't tell my doctors that I do sex work or use drugs, and I do not want to jeopardize my hormone or surgery access. I asked for PrEP in my trans-specific health clinic, but no one followed up with me. I feel judged about my sexual behaviors when in the trans health clinic where I receive care. Having peer support as part of the clinical visit, here's everything. And finally, I have been kicked out of primary care at a trans-specific clinic, and this is the only place I feel comfortable asking for PrEP. So, interestingly, we found that, separating trans and sexual health from primary care can actually be an ideal model for some participants. Interestingly, we heard from several participants that they really didn't want to talk about their sexual health or drug use with their primary care providers because, they were really focused on their surgery referrals and getting access to hormones. And they perceived that if they shared, that they were doing sex work or, had many partners, that might jeopardize their access to gender-affirming services. Also, just the appointments and business hours of the clinics were challenging. And and then interestingly, while the majority of participants were on hormones in our study, some did not want to be on hormones. And so they, didn't really feel like they needed to have that co-location of services. We are doing another study right now through the HIV Prevention Trials Network called HPT 091, which is a study studying specifically the idea of co-locating gender-affirming hormones and PrEP at the same site. And so participants are randomized to either getting them co-located or immediately or after a 6-month delay. And so that is something that we'll have more information about as well. And then finally, I want to tell you a little bit about the texting component, the PrEPmate. So PrEPmate is it's a mobile health texting platform that uses text messaging to promote adherence to PrEP and retention and care. There are several potential components of it. There's a bidirectional texting where you can just text back and forth with the participant and the staff in the clinic. There's some automated weekly check-in messages, which patients can choose the type of messages they receive, which are to more serve as daily pill reminders. And I'm sorry, there's weekly check-in messages, which check in with them every week on how they're doing. And then there's automated daily pill reminders. And so these are some examples of the different categories of text messages that they could receive, which serve as pill reminders. So there's trans information, trans history, trans affirmations, and then there's some fun facts, quotes, and sex facts as well. And so people can opt into any or all of these categories. They can also opt into no daily messages and just have it, be available to talk with their navigator or their provider. This is an example of the dashboard that we used for PrEPmate. We did sort of revamp this, but this was sort of the old design of it. But you can see an example of how's Truvada going, and they reply good, and then these are some of the reminder messages that they got. So we found that in the study, use of PrEPmate was actually quite high. About 153 or 135, opted in to using the bidirectional texting platform. About 54 chose the weekly check-ins only, 2 chose the daily reminders only, and 61 chose both weekly check-ins and the reminders. And the median number of texts received from participants during the study was 52. And we found that they generally liked PrEPmate. Most felt that they were of excellent quality, that the daily pill reminders and weekly check-ins helped them take PrEP, and that they wanted to actually continue using PrEPmate after the study. And nearly all participants surveyed believe PrEPmate should be offered as an option for people taking PrEP. And PrEPmate is now, it is one of the CDC evidence-based support interventions. And we've now partnered with WellTel, which is a organization in Canada, to make it more, to scale it up and make it more available. And it's tapping into a lot of the EHE, ending the HIV epidemic projects across the country. So I wanted to end with this slide, which was a survey done in 2017 when the project was just starting, and then 2020 when it was ending. And this was a survey in San Francisco, not just focused on stay, but just in general. And what they found was that there were significant improvements. So the purple is 2016, 2017, and the blue is 2019 to 2020. And you can see that awareness went up a little bit. Provider conversations about PrEP doubled. Use of PrEP went from 15% up to 45%, and adherence also went up. So it was great to see this. Being in the study was actually associated with PrEP use in the study. So this was led by Erin Wilson. So just to conclude, PrEP uptake among trans non-binary individuals in the Bay Area was high when offered in the trans-friendly primary care, as well as the PrEP-only clinic. The trans-friendly PrEP-only clinic did facilitate enrollment and was associated with high levels of retention and adherence. We did see the importance of social determinants of health on PrEP adherence, and particularly want to call out housing and food insecurity issues. Hormone use was not associated with tenofovir diphosphate levels in this real world cohort, which was reassuring. And finally, addressing social and structural determinants of health are really critically needed to support HIV prevention needs in trans communities. And with that, I'll end with all the acknowledgements of the participants in the study that are social influencers, all the navigators and staff at the sites, and our co-team members on the state team. And finally, the CHRP, the California HIV/AIDS Research Program, for funding the study.
Thank you, Dr. Liu, and feel free, folks, to give some reactions or comments in the chat. And I'll hand it over to Zami for questions and discussion.
Hello, everyone. Thank you so much, Dr. Liu, for that amazing presentation. My name is Zami Tinashe Hemingway. My pronouns are Zami, he, and him, and I'm the Capacity Building Assistance, or CBA, Gender Affirming Care Project Manager with Denver. So excited to lead this discussion with you all. So we'll be checking the chat periodically to see if you all have any questions. Please feel free to drop them in the chat or raise your hand or unmute if you do have one. But to kick us off, one question that I have is, how did you all identify the organizations and clinics that you're going to partner with when rolling out the STAY study?
Yeah, that's a great question. We, based on the model, the STAY model, where we were trying to embed this within trans primary care clinics, we really wanted to find collaborating partners that had long-standing experience working and serving the trans non-binary communities in the Bay Area. And so, Aaron Wilson and I, as the co-PIs, looked at who are the clinics that are serving these populations. Some of them Aaron had worked with before and had ongoing relationships for prior research studies. And so we already had a collaborating experience with them, although some of them were new. But we really wanted to find places where, all the staff already had lots of training and experience working with the population. And, the PrEP part was new. And we could provide the expertise to help integrate it into the clinics, but the, experience working with the community and serving the community, that part they already had down.
Awesome. Thank you so much, Dr. Liu. The next question I have is, how did the STAY study intentionally include non-binary folks who are assigned female at birth? So we saw some of the demographics, but I'm wondering, how did that break down into non-binary, AFAB folks versus transmasculine folks?
Yeah, I'll have to go back to that slide, but I don't know if we have it broken out by their assigned sex at birth in terms of non-binary, which we can certainly get. But overall, about 6%, identified in that category. And we did predominantly have male at birth participants in the study, I think reflective of the burden of HIV and who the clinics were seeing. But we did intentionally want to have, the broadest umbrella possible and not, exclude folks. And so we did see, a spectrum of gender identity in the study.
Awesome. Thank you so much. So the next question I have is, we know that based on the recent HIV surveillance, that about 40% of newly diagnosed folks with HIV identify as transgender men. And looking at the STAY study, but also just looking at things historically, I'm wondering, we know that trans masculine population or trans men are less likely to be on PrEP or less likely to be offered PrEP. And so my question is, what was some of your barriers and challenges in trying to get transgender men as a part of the STAY study or to get them on PrEP?
Yeah, that's great. So, we did have social influencers who were from the trans masculine community, and we definitely wanted to include that. And one of our peers was also a trans man, and that did help with some outreach in the community. But I think it was since we were largely doing clinic-based recruitment, it was largely, who were the patients that the clinics themselves were recruiting and accessing. And so a larger proportion of them were trans women that they were able to recruit. So I think it's a great point. And we've been trying to, in future research studies, really make sure that trans men are included in the project. And right now we're doing the study that's an injectable PrEP study, and it's for both cis and trans men. So we were happy to see that.
Awesome. Thank you so much. Dr. Bloom, I see your hand raised. Go ahead and unmute.
Thank you. Thanks again, Dr. Liu, for the wonderful presentation. A lot of just so much rich information. And I really appreciated that you had the settings of existing clinical sites as well as the study clinic. I think that was really interesting to hear about. And one reflection that I had was a lot of the barriers you were mentioning that study participants brought up around receiving PrEP and primary care, I think are not specific to transgender individuals, but maybe amplified among people who are already reporting. I think you said like a quarter of people had negative experiences with healthcare in this study. A lot of mental health history and structural barriers to healthcare. So I just wonder if you can reflect on that in terms of like how this made you think about providing PrEP and primary care in general, and then specifically for transgender and non-binary individuals, addressing those barriers, or if we need to just start thinking more outside the box and skipping the whole primary care thing altogether.
Yeah, that's a great question and observation. I think that many of the barriers were, kind of cut across, a lot of different populations, and we were just shocked when we tried to implement, PrEP really wholeheartedly, that the clinics were just, it was too much, too quickly, and so I do think that the having that the peer be able to sort of be the glue of the whole program, like, was really important in making it a welcoming space, and it was because it was outside of their normal setting that they were used to. It did take a little getting used to coming to a different site, but when they were welcomed by the peer and they felt really welcomed, that really felt that, overcame many of those challenges. In terms of the social determinants and such, I think that we do need, different models of care to help address, those models that or the barriers which, may not be able to be completely addressed in primary care, or people just may not want to go there. So I think I'm all for, new delivery models and trying to test to what works. Looks like Thomas has a.
Yeah, thanks, Al. No, really, I keep listening and kind of thinking and knowing community here in San Francisco and the racial breakdowns with regards to folks either accessing services based on their race in the city and county of San Francisco as a trans person. So either Asian or Latino or African American or white. And so there's a lot of kind of pre-existing relationships there that are for better or for worse. And so I'm wondering if you saw any of that in this particular space, trying to, I think people often think of the trans community as a homogeneous community, right? But there's a lot of diversity within it in itself as well. So combined with people kind of all knowing each other, can get pretty complicated pretty quickly. And
Yeah.
did that present in any way?
Well, I mean, it's definitely a very tight-knit community. And I think part of it was also, you know, initially when people came, it was word of mouth that, you know, people had a good experience and they would tell other people. It can cut the other way. If one person has a bad experience, that can spread really quickly too. So we were very aware of that. And, you know, I think we did at the clinic here, we did see a, you know, diversity of race ethnicities. And I don't think that was different than the primary care clinics, but each of the clinics did have some differences. And, you know, I think the, you know, at the clinic in Fremont, there were some I think a greater number of Latinx individuals and such. So definitely, you know, there's some people, you know, feel comfortable going to certain clinics, or they know staff at some of the clinics, and then that really attracts them. And then sometimes the staff leave, and then that causes some disruption. But that's, I think, just part of the story.
Yeah, for sure. Thank you, Al. Good work.
So we have one more question that's in the chat before we wrap up. If maybe you'll be able to answer that, Dr. Liu. It says, curious to know which ethnicities were put into other or multi-category. Were there any Native American identified persons?
Yeah, that's a great question. I'll have to go back and look at if we had, I think we did have at least a small number, but I don't have the exact number of that. We did have a number of people who identified with multiple race ethnicities, and so that was included in that category as well. But I can go back and look at that.
Awesome. Thank you so much. I'm going to pass it back over to Dr. Jess.
Thank you again, Dr. Liu. We really appreciate your presentation. Thank you, Zami, for your wonderful questions and guiding the discussion. And I just wanted to ask everyone to fill out the survey. Frank put in the chat that your feedback is really valuable, and we need it to be able to continue to provide these sessions. So thank you for taking the time to do that. Otherwise, we're going to end early today, give you back 15 minutes of your day. So appreciate your participation and attendance today, and we'll see you all back in March.
Thanks, everyone.